Hello, everyone, and welcome to this Mums and Bumps session on planning for pregnancy with type 1 diabetes. My name is Caitlin Parker, and I am an accredited practicing dietitian and a credentialed diabetes educator. I live with type 1 diabetes, and I've gone through two type 1 diabetes pregnancies. We'll be covering a couple of different things today, and the idea of this webinar is to help you work out what you need to do before you come pregnant, and also giving you a bit of an overview about what to expect in your journey through a pregnancy with type 1 diabetes. We'll go through our preconception checklist. We'll talk a little bit about your pregnancy team. We'll talk about what to expect, a little bit on diet. We'll talk about morning sickness, ketones, and any other challenges that we might have going through pregnancy with type 1 diabetes. What to expect after delivering your baby, and also the challenges and silver linings of pregnancy with diabetes. It can often feel quite overwhelming and stressful to go through this. So we just wanted to acknowledge those challenges and also try and think on the bright side as well. Starting off with our disclaimer, this information presented is general in nature. So everybody and every pregnancy is different. So use it as a general guide of what to expect. But as with all things with diabetes, you could be the exception to the norm. So it's important to consult with your healthcare team about your individual circumstances. With preconception, we, as someone with type 1 diabetes going through pregnancy, we go through all of the normal preconception stuff that someone without diabetes might do. So that could be making sure that our diet is good, getting our medications reviewed, making sure that our body is healthy, and doing things like stopping smoking if we're smoking. But we also do things like update our CGM access through the NDSS to planning pregnancy. This provides a further subsidy to the CGM sensors. We need to do our baseline screening for diabetes complications. So this is retinopathy, or getting your eyes checked, nephropathy, or getting your kidneys checked, and also our blood pressure. Your GP may order some thyroid screening tests. So this is just a blood test where they look at how your thyroid is functioning. You may be asked to start on a high dose folate supplement. So someone without diabetes would be on a folate supplement of around 0.5 milligrams, whereas when you have diabetes in pregnancy, most of the time they'll ask you to take a higher dose folate supplement, so 5 milligrams. This is likely going to be on top of any prenatal vitamins that you might take, as a lot of those contain 0.5 or less. We are also trying to get our blood glucose levels in control, or as in control as we can. So we're aiming for an HbA1c of less than 6.5, but the closer to 6%, the better, taking into account the impact that this might have on our hypos or low blood sugars. When we talk about this HbA1c target, it's all about reducing our risk. So this graph shows our risk of adverse outcomes on this side and our HbA1c down the bottom here. So you can see that the lowest risk of adverse outcome is here. So where the HbA1c is around 6 to 6.5. If the HbA1c is higher than that, it can cause or can affect how your baby develops. And if it is much lower than that, it may also have an impact on you or your baby's health. So the real sweet spot is around 6 to 6.5%. In terms of the preconception diet, we're aiming for a generally healthy diet, so not really anything special. It's a good idea to check in with a dietitian during your preconception appointments or time frame. And the point of this is to do a carb counting review. So we want to make sure that those carb counting skills are as good as they can be, because it often gets a little bit more difficult to manage blood sugar levels throughout pregnancy, and we want to make sure that the carbs are accounted for. We can look at our diet and make sure it's generally healthy to optimize our health. We want to make sure that we're getting enough of the vitamins and minerals that our body needs, so our nutritional adequacy. And we also want to make sure that we're getting enough carbohydrate, and we'll talk about that a little bit later. You can focus on practicing bolusing for different foods. So we want to make sure that we're confident giving the correct amount of insulin for the foods that we usually eat. We want to avoid alcohol and also reduce our risk of listeria and salmonella. So this is where you avoid things like soft cheeses, processed meats, that kind of thing. We're aiming to limit our caffeine intake to 200 milligrams per day or less. And this chart over to the side here gives you an idea about the amount of caffeine in different caffeinated drinks. So if we're talking about instant coffees, it's around 3 instant coffees per day. Decaf, it's a lot more than that. Decaf has only around 3 milligrams of caffeine. If we were to have something like a double shot cappuccino, that's around 150 milligrams of caffeine in a cup. And other ones can be a bit higher. So something like cold brew is higher in caffeine. We also want to make sure that our lifestyle is generally healthy when we're preparing for pregnancy. So we want to partake in regular exercise. This can also help with insulin sensitivity and prepare our body for the challenge that is pregnancy. The person to see here is if you need some more help is an exercise physiologist. So they can guide you with the type of exercise to do, as well as working with your credentialed diabetes educator. They can help you work out how to manage your insulin around exercise. We want to make sure that we're getting enough sleep. So most people recommend around 7 to 9 hours per night. We want to not smoke. And as we said, we want a medication review to make sure that the medications that we are taking are safe to continue taking during pregnancy. The people in your healthcare team you've got a few more people than if someone was going through pregnancy without diabetes. So we have an obstetrician and a midwife, and these were described to me as the baby's doctors or the baby's medical team. You also have an obstetric physician or an endocrinologist in pregnancy. And so if you think of this one as essentially your doctor or your diabetes doctor during pregnancy. You may also talk with a diabetes educator who has experience in pregnancy, and they will help you do things like adjust your insulin doses. Dietitian can be an important part of a healthcare team during pregnancy to help with nutritious foods and managing blood sugar levels around diet, and also any help with exercise or difficulty exercising. It'll be an exercise physiologist or a physiotherapist that can help us there. We mentioned diabetes educator as someone that can help adjust your insulin levels as you go through pregnancy. And this is because we have such a huge change in the amount of insulin that we need as we progress through pregnancy. So at the point of conception, if we took this as our normal amount of insulin that we take, during our first trimester, we have insulin sensitivity, or we tend to find that we need a little bit less insulin than usual, or you might find that you're having more lows than usual. As we progress further into the pregnancy, we start to become a little bit more insulin resistant, and this insulin resistance continues to increase through our second and third trimester up until we get to around 36 weeks, and then it plateaus, and that insulin resistance dramatically drops once the placenta is out. Like as soon as it's out, your insulin requirements go back to normal or even less than normal. This period here where we see this rapid increase in insulin resistance, your insulin levels will become much higher than normal. So two or close to even three times what you were taking prior to pregnancy. And that is completely normal. Um, those amounts of insulin that we need to take changes week to week or sometimes even twice a week. But you have such a supportive healthcare team behind you that it really isn't just you. You've got so much advice to help you with those insulin changes. So you find out you're pregnant. Now what? So the first step will be to book in with your GP as soon as you find out that you're pregnant, and they will order a blood test to confirm that you're pregnant and also conduct the initial pregnancy screenings. They will write a referral for a dating scan, and they will also refer you to see your obstetrician. So for the public care pathway, the hospital that we go to is King Eddie's, and we don't need to wait to see someone at King Eddie's. They will take you as soon as you know you are pregnant. Um, so the waiting period or waiting until after the first trimester doesn't apply to people living with diabetes. For private, again, the GP will write a referral to the obstetrician, but you may also want to link in with a diabetes educator as soon as possible as well, and they can help you with those insulin adjustments as you find that your insulin sensitivity is increasing. With those care pathways, so we have the public pathway or the private pathway. Both of those pathways will give you very good care during pregnancy with diabetes, but there are a few little differences between them. So, public, we have regular follow-up from the diabetes educator, midwives, obstetrician, obstetric physicians, and dietitians through King Eddie's. With the private pathway, we will also have regular follow-up with a diabetes educator, midwife, obstetrician, obstetric physician, and dietitians, but you will be able to choose your own healthcare team. The public system, it's minimal out-of-pocket costs. The private system, you will need private health insurance, and it's gold level usually to cover maternity, and this covers your hospital stay. But you will also have out-of-pocket costs for all the appointments leading up to your hospital admission. So it'll be only a Medicare rebate for those appointments, and almost always there is a gap. You may also have out-of-pocket costs for some of the in-hospital care. So the pediatrician may charge separately, medications will be charged. You may have to pay a gap for the anaesthetist if it's required. But the benefit of private over public is that your partner can usually stay the entire duration of your stay as a boarder. The healthcare professionals in the public system are specifically trained in diabetes in pregnancy. So there is a diabetes in pregnancy team over at King Eddie's, and they're very, very knowledgeable about helping people who are pregnant with diabetes. And on the flip side of that, with our private system, again, you can also access clinicians who are specially trained in diabetes in pregnancy. It's just a matter of you getting referrals to those people. Our blood sugar targets during pregnancy do change, and this is another thing that makes it a little bit more challenging. So we have to look at our blood sugar levels during pregnancy, whether that is with CGM or with finger pricks or with both. We are still aiming for 70% time in range as we are out of pregnancy, except the target range changes from 4 to 10 to 3.5 to 7.8. So it gets a little bit tighter and a little bit lower. We're aiming for fasting levels to be between 4 and 5.5, 1 hour after a meal to be less than 8, and 2 hours after a meal to be less than 7. These targets are really strict and really hard to meet all of the time. So just focus on doing your best, working towards these numbers, and being kind to yourself if you don't always achieve them. You've got your healthcare team behind you, helping you to do things like your insulin adjustment or choosing different foods to eat. Um, but ultimately, these are just the numbers that we're working towards. The aim of these tighter, lower targets are to reduce our risk of macrosomia. So that's a larger than normal baby and the risks associated with that. We want to try and reduce the risk of low blood sugars in the baby after the baby is born. We want to help that baby, we want to help facilitate normal development in that baby. And we also want to minimize the risk of hypos in the mum. We also get additional care and monitoring. So, on top of all of the normal pregnancy scans and tests, we also have an extra heart check for the baby at around 24 weeks. So, this may be during your 20-week scan, or it could be a separate heart check scan. You also get extra growth scans in the third trimester. So, they really want to make sure that that baby is growing as it should. We also need to do some additional complications monitoring. So the retinopathy or our eyes, the risk of this is increased if the blood sugar levels are rapidly dropped, as they sometimes are during pregnancy. And there can also be some changes to your eye normally during pregnancy as well. So it's important to have a check-in before pregnancy and during. They're recommended pre-pregnancy, once per trimester, and then 1 year postpartum. We also get our kidneys checked as well, so that looking for nephropathy, and they will look at protein in your urine to scan for this or check for this. One of the things they're looking for when they do look for the protein in the urine is this preeclampsia, which you may have heard of before. It's a pregnancy complication that's characterized by high blood pressure and the presence of protein in the urine. The actual cause is not fully understood, but it's likely related to the formation of the placenta and the blood vessels within that. What they have found is that if you live with type 1 diabetes, you're at 2 to 4 times more likely to develop preeclampsia than someone without diabetes. So it occurs in 15 to 20% of pregnancies if the mother has type 1 diabetes, and it occurs in 2 to 7% of the general population. It's thought to be more likely to happen if you have pre-pregnancy insulin resistance, if you have a higher HbA1c in the first trimester, or if you have lower vitamin D levels and higher cholesterol levels. Birth is the only known cure in inverted commas, but the research is continuing to work out whether or not a low dose aspirin will help to prevent or reduce the risk of preeclampsia during pregnancy. One of the things that we spend a lot of time talking about in terms of diets with people with type 1 diabetes, especially in pregnancy, is carbohydrate. So the research around the safety of a low carb diet in pregnancy is very limited. So it's very hard to study in that it's not ethical to restrict carbohydrate in a woman that is pregnant just to see what happens. So there really is very limited research in this area. The general recommendation is to consume around 175 grams of low GI carbohydrates each day, spread out across the day. So they recommend across 3 meals and 2 to 4 snacks. Um, the arguments for carb consumption during pregnancy are to ensure that there is enough glucose crossing the placenta, so to fuel your baby for normal growth and development. We want to prevent ketones, which can happen on a low carbohydrate diet. And they're uncertain about how ketones affect the baby's brain development. And we also want to reduce the risk of nutrient deficiencies for the mother if we're cutting out high carbohydrate foods. So with that 175 grams of low GI carbohydrate, this could be split up something like this. So 30 to 45 grams for meals and 15 to 25 grams of carbohydrate for snacks. So it could be something like porridge made with milk topped with berries and nuts for breakfast. It could be a milky coffee and a handful of nuts mid-morning, a protein and salad sandwich with a piece of fruit, grainy crackers with cheese and a high protein yogurt mid-afternoon, Um, a mixed meal for dinner following our plate proportions model, where we have half of our plate veggie, one quarter high carb foods, one quarter protein containing foods. And then it could be something like a piece of fruit toast with peanut butter before bed. One of the things that often happens in the first trimester is nausea. So, morning sickness or all day nausea. Some of the strategies that we recommend to help with this is eating small amounts of meal more often. So, skipping meals or becoming really hungry can make the nausea feel worse. Staying hydrated, and that can be taking small sips of fluids if you don't feel like you could stomach a lot at once. Plain starchy foods tend to be better tolerated when you're not feeling well. So this can be things like dry crackers, dry cereal, toast or fruit. Cold food tends to give off less odor, so can often be better tolerated than if the food is hot. You can talk to your pharmacist about whether taking a B6 supplement or ginger tablets, teas, lollies, ginger ale, diet or not, as both of these can help with nausea. You can trial different brands of multivitamins. Some of them tend to be better than others, depending on the type of iron, usually that's in the supplement. And sometimes it can be better if you take it before bed rather than first thing in the morning. If your nausea is severe, please speak to your healthcare team about medication options. And often the earlier you start these, the better because you can kind of get on top of things and not feel sick for days at a time. And we can also time our meals around this anti-nausea medication if we need to as well. So we've mentioned before about ketones in pregnancy, and we want to try and avoid this if we can. So when insulin levels are low, the body breaks down stored fat and produces ketone bodies. Without enough insulin, this process becomes unregulated. And when we get too many of these ketone bodies building up, the blood can become acidic. The causes of ketones can include not enough insulin, illness and stress, and also pregnancy hormones. So this also changes the body's capacity to deal with or to balance acids and base or maintain our body at the right pH. So when our body breaks down this fat tissue or adipose tissue, it produces the ketone bodies, and we need enough insulin to be able to deal with those and make sure that they don't become unregulated, which changes the pH of our body. In pregnancy, ketones can be present even without your blood sugar levels being high. And DKA or diabetic ketoacidosis in pregnancy is very risky for both the mother and the baby. So, in preparation for our pregnancy, what we want to do is review our sick day plan. So, your sick day plan will give you information or steps to do if your blood glucose levels or your ketone levels are higher. We want to check for ketones if we feel unwell or if our blood glucose levels are elevated. And we want to seek medical care if our ketone levels are above 0.6. So moving on to the big day. So most mothers with type 1 diabetes deliver their babies at around 38 weeks. Um, this is a decision made, I guess, in consultation with both you and your healthcare team. But the aim of having your baby early is to reduce the risk that may happen if your pregnancy progresses past that. So this labour may be induced or it may be a scheduled C-section. Um, when you are going through labour, your insulin requirements typically decrease during labour. It's essentially like a physical activity, so you may manage it similar to what you would with exercise. And it's important to monitor your blood sugar levels and adjust your insulin doses as you need to. After your baby is born, it might require extra care after delivery. Um, so this could be due to low blood sugar levels, or it could be for help with breathing. Um, the way that this comes about, or the low blood sugar levels in the baby, is that if Your blood supplies your baby, but your baby's pancreas works as it should. So if your blood sugar levels are higher, that extra glucose will be going to your baby as well, and they will be producing insulin to deal with it higher blood sugar levels. As soon as the baby is born, it no longer has access to your blood sugars, so the blood sugar level will likely be lower, but it is still producing more insulin than a baby without the elevated blood glucose would be doing. So sometimes that can make the baby's blood sugar level drop too low. It's generally only temporary, and they will treat the hypo however um, they need to help make sure that your baby stays well. Once you have given birth to your baby and the placenta has come out, your insulin resistance dramatically drops. So you become much more insulin sensitive. You have a much higher chance of having a low blood sugar level. And after your baby is born, your blood glucose targets relax a lot. So instead of trying to aim for a tight low target, the main goal is now to prevent low blood sugar levels, especially when you're handling a really young baby. If you are planning on breastfeeding or expressing milk, your insulin levels might need to be adjusted around feeds, similar to what you would do with aerobic exercise. Moving on to our extra challenges. So, having a pregnancy with type 1 diabetes is automatically classified as a high risk pregnancy. And because of this, our option for public uh, pathways is generally only King Eddies. We have to try and manage that morning sickness during the period where we have increased insulin sensitivity. So you're likely going to have periods where your blood sugar level is low and you really don't feel like eating. We are trying to achieve a really tight blood glucose control when we're going through the most variations in our insulin sensitivity ever, thanks to our placenta. And you may find that this worry of the tight blood glucose control can take a toll on your mental health, and there you may feel guilty. Someone is always looking at your blood sugar levels, and sometimes they don't truly understand what they're looking at or how hard you are working to try and achieve that. So just try and be kind to yourself and reach out for help if you need it. You may also find that you have a fear of low blood sugar levels and you may have decreased hypo-awareness. So you may go much lower than you would before without really realizing it. And also there are increased risks to both the mother and the baby. But your healthcare team will work with you and try to minimize these risks. So things like starting a low dose aspirin and a calcium supplement to reduce our risk of preeclampsia. The good things or the silver linings about pregnancy and type 1 diabetes is that we get fully subsidized CGM before, during, and 3 months after we have our baby, which is pretty good. We get lots of close monitoring and extra scans, so more growth scans, particularly during the third trimester, so you get to see your baby more often. Access to the awesome team at King Eddie's if you choose to go public, regardless of where you live. King Eddie's is a great hospital, especially the diabetes team that they have there. And you can access them no matter where you live. You don't have to live in the King Eddie's catchment. And you don't have to do the glucose tolerance test, which is a very horrible test to test for diabetes, which we already have. Once you've had your baby, you may start thinking about planning for the next one. And this one can sometimes be a little bit harder in that you've got a little baby to look after as well, or a toddler. But it can also be a little bit easier because you kind of know what to expect now. When we're planning for this next baby, again, we want to optimize our diabetes management um, as much as we can while caring for another child. So some of the things that can be good to work on or can be good to think about is focusing on our pre-bolusing as much as we can and trying to do this safely. Stay active. So whether this is planning some time for yourself, so having someone else look after your baby while you do some physical activity, including your baby in your physical activity. So whether that's walks with the pram or playing on the playground with your older kids, making use of a creche if that's what you like, so that you do get that time to do exercise by yourself. Choosing low GI carbs. If you choose low GI carbs, they're slowly absorbed. And because of this, they don't tend to cause as much of a spike in our blood sugar level. So if you forget to bolus before your meal or you aren't able to pre-bolus, the postprandial or after meal spike won't be as harsh as if you choose a high GI food. We want to spread our carbohydrate portions throughout the day, and we also want to be kind to ourselves. It is hard, and we're all just doing the best that we can. For more info and support, we've got the PDC Mums and Bumps group. So they have regular meetups where you can chat to other mums with type 1 diabetes who have children. There are Facebook groups. So there's the type 1 diabetes and pregnancy, bump baby and beyond for Australian women. The NDSS have a pre-planning checklist. Um, so all the things to do before falling pregnant. And the NDSS also have a guide called Having a Healthy Baby Guide for Women with Type 1 Diabetes, which has some extra information in it as well. The references that we used are listed here. And please feel free to ask any questions. Um, Happy to talk about whatever you need.